the treatment landscape is changing so quickly. And historically, there's many different types of clinical trials. There's clinical trials called, phase 1, first in human, never been tried in people before. And that's one situation. Then there's clinical trials where phase 3, we already have an excellent standard of care, and we have this new treatment that we think is even better than what we're doing. And those types of clinical trials are very different than the early phase, first in human type of clinical trials. So whenever discussing clinical trials, whatever the cancer type is, it's always important to understand, no placebo involved. That's a common question I get. Everyone's getting treatment. And the goal of the trial, is it to improve upon standard of care, or is it in a setting where we don't really have other treatment options? So typically drugs are approved in the relapse refractory setting where patients don't have many other choices, and then slowly moved up. So right now we have so many good new options in Hodgkin lymphoma. The biggest challenge is figuring out how to combine them or sequence them to minimize side effects and maximize how effective they are for our patients as early as the front line. So since there's so many treatment choices, many times the best choice could be a clinical trial because it gives access to the more novel therapies that are, many times FDA approved therapies for relapsed refractory disease. You're just using them slightly earlier on in the disease course because they've already demonstrated that they're very effective with a favorable side effect profile. So it's really important to talk about it in detail with your provider. So when I have a patient coming in, I always try to gauge how much do they want to be part of the conversation. Some patients say, I'm very overwhelmed by all of this. Please give me the brief summary and then talk about what we recommend. Other patients come in with multiple scientific articles that they've read after, their third opinion, and they want to talk about the details of the study. So whatever your goal is and whatever you need to help figure out what's right for you, it's very important to talk about that with your provider so we can personalize and make that conversation as helpful for you as possible. But what I typically do is I say, this is the situation. These are our standard of care options, or this is our standard of care. And I do or do not have a clinical trial that you potentially could participate in. Here's what it is. Here's the potential risks. Here's the potential benefits. And then, we talk it out. And whatever is best for that patient is typically how we proceed. So I think the availability of the internet and many different medical resources or non-medical resources, it is appealing to get your result from your MyChart and immediately start Googling and finding, all sorts of things that may or may not be applicable to your case. So I would really advise people, newly diagnosed Hodgkin, your first source of information should be one of your team members who's taking care of you, because there's a lot of nuances and it's easy to go and get overwhelmed by the information on the internet. And then to use excellent resources that can provide further information for your own research. So LRF, for example, and other similar organizations serve to do that, to organize accurate medical information that's patient-friendly to help you understand what's going on, do your research, and come to your appointments with the questions that you want addressed. So I think oncology right now is just really exciting. We're no longer thinking about cancers based on where they came from, breast cancer, colon cancer, lymphomas. We're thinking about what's driving the cancer. What are the molecular pathways that are abnormal? What's the immune system doing? It's really an era of targeted oncology where we're treating not only the disease, but the patient. And we're understanding so much more. Hodgkin lymphoma historically has been a very curable cancer in general. Overall statistics say about at least 80% conservatively of patients are cured. But that number is probably inaccurate and is changing and improving as we get all of these new treatments. So remain hopeful because we were already doing very well with classical Hodgkin lymphoma. We're doing much better now, such that when people ask me what their chances of survival are and cure are, I say I honestly don't know because our statistics don't reflect what's going on right now. It's changing in a positive way so frequently that just stay engaged, stay hopeful, stay active, stay healthy, keep your immune system as healthy as possible, and that's what will lead to the best outcomes. Lymphoma Research Foundation is wonderful. They've got a lot of excellent education about what is Hodgkin lymphoma, what are the different treatment choices, dietary suggestions, resources to help the patient through their treatment, support networks, any sort of other, even sometimes financial type of assistance advice if you maybe would qualify for some sort of grant so that you could get your treatment. So there's a lot of different resources, and those resources I've seen expand dramatically during the COVID pandemic, and have really helped our patients maintain their relationship with their providers, continue their oncology care, which we couldn't, pause during the pandemic, and helps direct them to that good, educational, accurate, scientific information. So when they do their own research, they don't end up with misinformation that can give false hope or also a lot of undue stress. So absolutely a diagnosis, absolutely through their treatment. But for many patients, it's a whirlwind. You're diagnosed, you start your treatment, you're done anywhere from a few to maybe 6 months later. And then it really sinks in what you just went through. And that survivorship period actually can be one of the hardest periods for many patients with lymphoma, just given how things unfold. You're no longer in that patient role. You're trying to get back into your social life. You're trying to get back into your work or school or whatever that is. If you're a young patient, it commonly happens at a pretty challenging time, whether you're finishing high school, trying to go to college, trying to start your first job, whatever that is. So LRF can certainly help with that kind of survivorship transition. And even as you go along, this is something that people live with then for the rest of their lives. They went through this experience, and it can affect them in many different ways as they move forward. So having a resource like LRF is obviously critical in the beginning and during the treatment, but also, many of my patients develop a lifelong relationship and continue to use their resources that LRF has, for many years after they're done with their therapy. So in the relapse refractory setting, we've moved away in some ways from chemotherapy and are using more treatments called immunotherapy that help train the immune system to recognize and kill the Hodgkin lymphoma. So there are theories that we probably all have several cancers growing in our body at all times, and the immune system recognizes them as abnormal and kills those abnormal cells before they turn into what you and I think of as a clinically apparent cancer. This is called immune surveillance. And in certain cancers, such as Hodgkin lymphoma, that immune surveillance fails, and the cancer cells trick your immune system to look like your normal heart cell, your normal skin cell, your normal lung cell. And they have signals that tell your immune system, don't attack me, I'm supposed to be here. What these immune therapies do, called checkpoint inhibitors, and there's several available now for relapsed Hodgkin lymphoma, is they retrain the immune system and take those cancer cells out of hiding so that your immune system can again recognize them and kill them. And those are called nivolumab, pembrolizumab, approved in the relapse refractory setting and being investigated in the frontline setting in combination with chemotherapy or in elderly patients that are unable to tolerate chemotherapy. Because it's a non-chemo approach. You're just basically retraining the immune system. So it's trying to, again, minimize the amount of chemo we're using and taking these novel approaches like retraining the immune system to treat Hodgkin lymphoma in the relapse refractory setting and the upfront setting.